Our second presentation is Spasticity Management, presented by Natasha Mackinley, who I believe is a person with lived experience. Stacey Wray is a registered nurse at the Adult Spasticity Clinic at the Glenrose in Edmonton. Hardeep Kainth is a physiatrist and is the medical lead of the spinal cord injury program at the Glenrose in Edmonton as well. And for those who aren't aware, the Glenrose is the rehab center for Edmonton Zone and surrounding areas. Take it away, guys. Go ahead and share your...
All right. Thank you for that introduction. Let me just sort this out. All right. Thank you all for the opportunity to present today. 380 people. This is amazing. Spinal cord injury, the practitioners in spinal cord injury are really passionate about spinal cord care. And so having the opportunity to speak to so many people is amazing. So thank you to the organizers for organizing today. So spasticity, just like neurogenic bowel, a huge topic that we're trying to condense down from like a 1 hour presentation down to like half an hour. So bear with us here. We're going to, oh, is this on the way? There we go. We're going to go through kind of pathophysiology of spasticity, describe some of the clinical presentations, review some treatment options, and then speak to Natasha's experience with spasticity and how she felt with kind of the treatment and what we do. So, definitions. A tough one in the world of spasticity. Started out with Lance in 1980 as a velocity-dependent increase in muscle stretch. As you see, as we go through time, they get more and more complicated. Now we've added disordered sensory motor control. We know it results from an upper motor neuron injury. We know it's a disorder with both sensation and motor control. And then the final definition from Lee is very, very convoluted, but the most precise. And again, we're talking about hyperexcitable descending and issues with inhibition, but mainly it's an exaggerated response to the stretch reflex, right? So that's the one thing to know. So the epidemiology of spasticity, these are the main 5 populations that we're going to see in clinics for spasticity. So stroke, multiple sclerosis, cerebral palsy, spinal cord injury, and then traumatic brain injury. We also do see a few people with ALS and hereditary spastic paraplegia, but they're very, very small numbers. So as you can see here, 70 to 80% of spinal cord patients end up getting some form of spasticity that requires some treatment. So one of the first big things from providers is, how do you differentiate between spasticity and dystonia? So it's complicated, right? So spasticity, like we said, is this kind of velocity-dependent hyperexcitability of the stretch reflex. Spastic dystonia is the really confusing term in here. It's like the middle of both of them. But really what it is just the tone, that tonic contraction of that muscle where it's just rigid. And then dystonia is you're not even moving the muscle, and you could be doing something completely normal, like walking, and your muscles are going to develop a type of posturing or an involuntary movement when they're not even being stimulated or not even trying to be activated. And so it's very complex because it goes right from all throughout the central nervous system, right from the brain down to the brainstem, into the spinal cord, out to the muscles. So we have lots of different reasons for us to develop spasticity, and they all have an effect on the final end pathway of that muscle stretch reflex. So we have altered mechanical properties within the muscle itself, which can lead to kind of that term contracture. We have involuntary muscle activation because of excitable pathways from the central nervous system, from the brain coming down the spinal cord, and the loss of inhibition, which is key. We also develop these spinal reflexes that kind of go unabated to the spinal cord and back to the muscle. And these like stretch reflex arcs occur, which we struggle to handle. And then we also get cutaneous or nociceptive pain-like reflexes. We call them kind of withdrawal reflexes that stimulate these responses. And that's why when a patient with a spinal cord injury maybe has a urinary tract infection or has a pressure injury, those can cause a large increase in spasticity. So these all together, we have to think about all of these things. So the way I like to think about this is thinking about just motor control in general. right? So if we think about how you're going to build a bridge, right, you need to first survey the environment and you need to plan out that activity. And the way you're going to do that is your high levels. Your brain is doing this. So this is your visual, like occipito-parietal, your acoustic, your basically your frontal, lateral, premotor. All of these areas are going to be planning, planning, planning. What do I want to do? How am I going to do it? Then we've got kind of the middle level, which is your motor preparation. These are your motor cortexes, your basal ganglia, and your cerebellum are going to start planning. How are we going to really do this activity? And then kind of bringing in the labor force is the execution, and that's your primary motor cortex via your pyramidal tracts, which is your corticospinal tracts, actually going down to your ventral horn and your spinal cord and out via your efferent nerves to the muscles, the end organs, to actually do these tasks. And that's the oversimplified version of it, because there's lots of tracks coming down from the brain down the spinal cord that have small changes that can happen to how we move and do things. And so when we look at that supraspinal influence, there is lots of these kind of oh, this is fancy slides. Lots of these tracks. So you've got the reticulospinal tract, and they have a big impact on the muscle stretch reflex. So we have to think about how these guys impact the way that we're moving. But remember, it's really because of the disruption between the brain, in the brain, or in the spinal cord, that is delaying signals, causing hyperexcitability and a lack of inhibition, which is then fueling this big muscle stretch reflex. So that's the supraspinal influence. Then we've got the spinal influence, and this is the muscle stretch reflex in itself. So within the muscle itself, we have these muscle spindles and the Golgi tendon organ. So these are kind of your afferent receptors within the muscle that sense stretch. And they're able, and the Golgi tendon organ is actually a proprioceptor. So it really tells the positioning of that stretch. And based on that information, your central nervous system is able to modulate how much stretch to give a muscle, how much power, exertion, stretch, all of these things. And we have these little interneurons that help us to stop an overreactive reflex happening, or to bring in kind of an agonist versus an antagonist muscle. And what we know is when you develop spasticity and a central nervous system issue develops, we lose these interneurons, the ability for the interneuron to modulate these stretch reflexes. So in actual fact, we end up developing kind of the ability to co-contract, where we're supposed to be activating one muscle and another antagonist muscle ends up contracting at the same time. And this is a direct problem with the interneurons not being able to down-regulate the opposite response, right? And this is where baclofen can be helpful, because baclofen in itself is a GABA B analog, and this helps us to kind of increase the inhibition of some of these overactive responses, right? So that's why it can be helpful with people, particularly more with spinal cord injury, because there is much more of the spinal influence in people that have spinal cord injury. Then we've got the peripheral influences, and this is what I was talking about before, this kind of withdrawal reflex. As you can see here, in this diagram, stepping on a pin causes a withdrawal reflex from your system. We have a flexor, kind of this afferent response that happens directly coming into the cord, and that causes, because of that lack of inhibition from those interneurons, causes that spinal reflex to be activated, and you end up getting spasticity or a spastic response. So if you put that all together, all of these things have a direct influence on the muscle stretch reflex. That is the common pathway to all of this dysfunction. So whether you have a brain injury, which is going to be more supraspinal, or a spinal cord injury, which is more obviously the spinal segmental influence, you're going to have slightly different presentation of spasticity that we'll talk about. Let's not forget the actual muscle itself. Because of the lack of neural control, we're going to get collagen disorganization happening, right? So here on the left-hand side, we've got a gastrocnemius muscle this is from the same patient, unaffected on the left side and affected on the right side. And you can see here directly, you've got fatty infiltration, a lack of architecture, a lack of organization, right? So one of the big researchers in the world of spasticity named this spastic myopathy. So we're dealing with this as well. At the actual end organ, we've got problems as well. So to sum that all up, brain, so Traumatic brain injuries are going to have a little bit more synergistic patterns. Remember, your brain is going to be responsible more for pattern generation. This is why you're going to get more like hemiplegic spasticity. Spasms are not as prominent because you don't get these hyperexcitable loops forming with the stretch reflex as much in brain injury, right? And therefore, they're going to be less responsive to antispasticity drugs. Whereas spinal cord, as we know, these synergistic patterns are going to vary, spasms are going to be more common, and they're going to likely respond better to antispasmodics. So again, kind of summarizing these things, if we look at it in terms of negative signs and positive signs, right? So the immediate changes are going to be that paralysis, then you're going to immobilize in a shortened position. The delayed changes are going to be the spasticity. So after a spinal cord injury, it takes anywhere from kind of 4 to 6 weeks for this hyperexcitable state to form. The same time frame as something like autonomic dysreflexia to start happening, right? So that's where you get all of the things we just spoke about. The muscle stretch reflex is more active, and you start to develop this tone or these spasms that interfere with your function. So what does that look like? We've got hypokinetic things like the tone, the dystonic reactions, the co-contractions, and then we've got the hyperkinetic things, the spasms, the associated reactions. So I borrowed some videos of my esteemed colleague, Dr. Lalit Satkanam, who's a worldwide expert in spasticity. So we'll go through a few of those videos because it's interesting to look at some of these. All right, anytime now. So this is a patient trying as hard as they might to try and extend their wrist, but they are having a co-contraction. So their wrist flexors are activating when they're trying to activate their wrist extensors. So this is a prime example of that co-contraction because of the loss of those interneurons, right? So you'll see here when you actually move the wrist, there is actually range of motion. Right? So it's not that there's not range of motion there, it's the fact that when volitionally trying to do this, they're unable to do it. This is an interesting reaction that can happen that we see in spasticity called an associated reaction. So in this video, this patient is trying to extend their arm out to touch Dr. Satkanam's hand, and at the same time, they're getting an associated reaction with a knee extensor moment happening, as you can see here. Again, disorganization within the central nervous system, right? This is ankle clonus, as we all know. So this is a good example of someone with ankle clonus. You can see they're basically in a knee flex position. So probably coming from the soleus, some gastroc involvement as well, but obviously they have looks like a hinged AFO as well on the left side. This is pre-treatment with botulinum toxin. And then if we look on this side, you can see how much smoother the gait is now after treatment, and their clonus is now improved, right? So that's a valuable treatment option that we do have that we'll talk about. This is very interesting. So this is a release flexor reflex afferent. So complex name, but this is someone with a striated toe or a hitchhiker toe. And this is because we have something called flexor reflex afferents, right? And they basically work by inhibiting extensor moments when you're trying to do an activity. So generally, when your foot is stroked on the bottom, you have reflex activation causing toe clawing. But when you have an issue with your central nervous system, that doesn't happen because of loss of regulation. So some people can have an overreaction of this, and they can develop an extensor moment here whenever the foot is touching the ground or they're standing, causing a striatal toe or a hitchhiker toe. So we have to treat this by injecting with botulinum toxin into extensor hallucis longus. So this is another interesting case of a dystonic patient. So you can see the big difference here. So we're not trying to activate this person's shoulder at all or asking them to do anything, and they are fixed in a posture with this kind of adducted, extended shoulder. Look at the fingers here in a very extended, fingers are abducted. So an interesting posture. So after treatment with botulinum toxin again, we're able to allow this patient to close their hand, able to have a little bit of swing, which is great, and the arm is held in a little bit more abduction and a little bit more anterior flexion of the shoulder. So that's a much smoother gait here. So remember, when we talk about spasticity, like we said, you've got that withdrawal response. So you have to look at if someone's coming in with an increase in spasticity at any point in the healthcare system, why is that in a short space of time? Is it because of wounds, urinary tract infections, poor bowel management, as we just heard of, hemorrhoids, bowel distension, or positioning in a wheelchair, like we hear about next? Right? Any of these things can cause an increase in spasticity. So really, if you want to be good, you need to do a really thorough assessment of all of these other things. Really, spasticity assessments, when we think about like from a physical exam point of view, are not great, right? We have the modified Ashworth scale, which is used most of the time, which is here on the right. The better exam to do is the Tardieu scale, but it's much more complex, and we don't generally have a lot of time to do this. This is where you kind of look at V1 to V3, which is moving the limb through velocity and seeing where you get a catch. And then it's also measuring R1, R2, the angle of when you get that catch. So it's way more information than just what you get with the modified Ashworth scale. So how do we do treatment? So if we look here, the biggest thing with anything regarding spasticity is management of expectations. And someone's gonna have to tell me time because my screen is like, I can't see. I think we're all right. Okay. Is managing expectations and goals, right? That's the main thing we want to make sure that we're doing. What is the patient wanting to get out of treatment is the biggest thing. Is that feasible without over weakening or causing them sedation from drugs? So that's the biggest thing, patient-centric care. Then we have kind of, is this generalized? We go down oral medications, or is it localized? Then we can think about focal chemodenervation with botulinum toxin. And then if you can't manage with either of these, then you have the option of an intrathecal baclofen pump, which Stacey's going to talk about in a minute. And then you do have the option of surgical intervention as well, either local or general, but generally when it's a bit more localized and you've been maybe doing focal treatment with botulinum toxin for a long time and you're not getting the results and you're kind of going up or down, then surgery should always be looked at as an option. It's quite powerful. So these are some of the medications that we use. I won't belabor or go into this too much. Baclofen, dantrolene, tizanidine are the big ones. Gabapentin is not used mainly for spasticity. I don't really know why it's in this table. Cyproheptadine is an older drug that's used that we're using a little bit more now, but does cause an increase in appetite. So some people don't like that. And then benzodiazepines definitely have a role with spasms. So if someone is having more spasms than tone, then we would use benzos. Botulinum toxin, we talked a little bit about it. The way it works really is to stop the release of a neurotransmitter at your neuromuscular junction. So it actually cleaves one of the proteins here, SNAP25, stops the fusion of this vesicle and stops the release of acetylcholine. So basically it paralyzes the muscle and it weakens the muscle. It's not forever. It lasts for about 3 to 4 months. So we can get some quite powerful changes by using this for people, but bearing in mind it can cause some weakness, right?
Hardeep, you
So
have
this is
about 6.5 minutes.
for the whole thing. Oh,
Yes,
snap.
sir.
Okay. I gotta speed up. All right. I'm gonna skip this. Skip this. Skip. It can, over time, botulinum toxin can cause some wasting, fibrosis, muscle atrophy with very long-term use. So we have to bear that in mind. Some of the things that we can use with botulinum toxin with it is going to be obviously strengthening, stretching, and then also using electrical stimulation with the opposite muscles. So if we're treating for example, the forearm flexors, then we want to use the extensors to try and to strengthen the extensors. I won't do the case. Like I said, surgery is very powerful in some of these patients, but you need to choose the right patients. And with that, I will pop over to Stacey to talk about intrathecal baclofen.
So intrathecal baclofen or ITB, I don't know if I can advance slides.
No, I'll do it. You tell
Okay.
me when you want.
Is basically an implantable pump system. The pump is seated in the abdomen with a catheter that runs through the abdomen and is inserted into the intrathecal space in the spine. So dependent on patient is where the level of the catheter goes up to. So the ITB process, appropriate patient selection is very important. Patients with generalized spasticity that cannot tolerate medications or medication doses have been maximized, or patients with significant spasticity in multiple areas where focal treatment is not possible due to overall toxin dose are kind of the most common patients that'll get an ITB pump, but cannot tolerate medications, might be even small doses of oral meds. And they just don't like the side effects. They're too sleepy, they're too tired while they're on those meds. So will go to a pump and then they can get off quite a few of their oral meds. Basically all their antispasmodics usually. And then setting proper goals and expectations is another important part of ITB. So the pump is good at what it does. It decreases tone generally in the lower extremities, but that's not always perfect for people. So the trial will have a lot. If they use their tone to do things, they may realize that a pump's not great for them because it knocks out all their tone and they then can't do things. It's also not the be all and end all. So people will still have, as Dr. Kainth said, spasticity is really dependent on noxious stimuli. So they'll still have spasms or they might still have tone at some point. It's not gonna all go away necessarily, and setting that expectation for people with a pump is quite important. Sometimes, especially in spinal cord injury, it's actually good for noticing noxious stimuli. So people will be quite well controlled on a pump, and then when they start having spasms, they know, okay, I got to look and see if I have a UTI. I have to check out whether I have a pressure sore somewhere, and they're looking for other things that are going on. When we decide that they need a pump, they'll go through a trial. The trial is a full day process. We do a baseline assessment the week before, and then we do the trial and assess them multiple times throughout the day, usually doing functional tasks if they can, and then manual muscle testing, range of motion, and mass scores. Then once they've had a trial, they'll move on to implantation, and we work with Dr. Sankar, so one neurosurgeon here, and he does all of our implants, and then we follow them up in clinic. So that's kind of what a pump looks like. The refills are done. The whole thing is contained in your body, and the refills are done by mostly the nursing staff here in clinic. It's a pretty simple process. You draw out the old drug, put new drug in, and then send them on their way. The pump will usually need to be replaced every 6 to 7 years. That's the battery life of it, and they just go in through the same scar and open it up. Device-related complications. So the pump can malfunction. It's rare, but it does happen. It will alarm if it does that. You can have catheter problems, like it migrates out of the spine, it kinks. The pump can erode the skin. There can be infections in those erosions, and then there can be loculations which collect drug in the spinal cord, and then surgical, like post-surgical problems can be things like hematoma, so a collection of fluid around the pump or the catheter insertion spot in the back. And then you can also have infection after surgery, which often leads to having the pump removed, and then a CSF leak. Biggest things with ITB, withdrawal and overdose. So biggest thing with withdrawal is loss of therapeutic effect, which will be a severe return in tone. Can cause seizures, often will cause hallucinations. So we have a little bit of a saying, it's itchy bitchy twitchy, and so people will get like skin crawlies, they get lots of tone, but it can lead to rhabdo, multi-system organ failure, and death. And then overdose is kind of the opposite. You can still get seizures, but you'll get really, really flaccid. So the tone will become absent. And then we have Natasha. Hi, Natasha. Oh, are you there?
Can you not hear me?
There we go.
There we
We
go.
can hear you. So this is Natasha. She's one of our pump patients. So I'll just start by asking Natasha, what was your tone like when we first started seeing you?
It was extreme. We frequently said that they were gonna stand me up because they just locked out in extension and I had no way of breaking it. So it would come to the point where it would actually flip me out of my chair and I had pretty low quality of life just because I physically couldn't move.
Yeah. Um, and what treatments did we try? Like the whole gamut of things.
So started on medications. We ran me through everything that was available 6 years ago when we started this. We tried the Botox injections, which did absolutely nothing. Um, and then from there, so it was probably about a 2-year process between trying medications and the Botox before we realized that we needed to switch to the pump direction. So then it was the trial and the start of that process.
Yeah. And what was your experience with your pump?
My first pump was great. There's a little bit more to it. But the first pump we did surgery, everything went totally fine. The pump worked great. And then a little over a year ago, we ran into some complications, and then it took us about a year to figure out what those complications were. And so September went in for the pump number 2, and then we had complications from that surgery, but so far everything's going great.
Yeah, you had the catheter was kinked and you lost therapy over that year.
Yeah.
Um, so we had to replace the pump. And then I guess overall, would you say your pump was worth it, even considering those complications?
Yeah, just even for the quality of life difference, it was makes a huge difference being on the pump versus the oral medication. The oral medication, I found like I was sleeping 12 to 14 hours a day and just functioning. But like that was it. Versus now I can fall back into the rhythm of a normal life. I can be at home safely and not be worried about falling anywhere,
Mhm.
which was normally the biggest problem.
Awesome. I think is that it for time?
I think we're good.
Yeah, I think we're good.
All right,
Thank you,
thanks very much.
Natasha.
No problem.
We can take some questions now.
Amazing. Thank you, all three of you, for that amazing presentation. And thanks to Hardeep for just really speeding through the last bit. I have a couple of questions for you guys. In which stage do patients need or can, access an ITB pump?
Stacey, go for it.
Yeah, so it really depends. We used to sort of think of it as a last stage of treatment. So you've tried absolutely everything else. You can't you can't do anything else, and they have lots of lower limb tone still. But it doesn't necessarily have to be a last resort if people aren't tolerating meds even from small doses, or you're thinking that it can help um just with being able to do things, and you kind of know from the beginning if they have a huge extensor tone or huge spasms and tone in their lower extremities, that you might try a pump earlier. Just because you trial them doesn't mean you have to implant them. So there's not necessarily one stage. We've sort of implanted people anywhere along the way. After trying, I mean, you'll want to try some things. You'll probably try oral meds, and you might try some injections, but you can,
Yeah,
there's no specific stage.
what I'll say to that is, yeah, it just depends on the patient. Like I'll have some patients that have botulinum toxin done every 4 months, but there's a big falling off effect after their toxin, and then they're really struggling, and we can't, even if we shorten the interval to inject them every 3 months, it's still too short. Sorry, too long. So those patients were very, very up or down. And even if they're ambulating, then we might decide to do a trial and see. But those people that are ambulating, you have to be very careful with so we don't over weaken them. And then they're not able to ambulate or walk again, right? So again, it's that very patient-centric approach. We have to do it. We do the trial, and then we see, do we get the desired effect? Do we meet the patient's goals?
Thanks, everyone. Another question from Samir. Can you please explain a bit more about using FES to antagonistic muscles? Reciprocal inhibition might occur, but guidelines here in the UK suggest that FES has less evidence as compared to other possible options like Botox.
So the way I describe that is it's not another option, it's an adjunctive treatment. So once you're using something like botulinum toxin, the idea is to develop balance back to your extremity. That's how I explain it to patients. So we know that spasticity is going to give you overall in your upper extremities, more of a flexor response, and in your lower extremities, a little bit more of an extensor response. So with that in mind, you're going to treat the muscles that are overactive with something like botulinum toxin, and then the antagonistic muscles, you want to try and strengthen those guys to at least give you a little bit more balance. This is very important when we come to the fingers. If we're in a flex posture and the fingers are really, really flexed over and we try and open up the fingers, we really want them to be stretched and get open a little bit more. So we can do that with splinting, and they can wear resting hand splints at night. But also, if we can then stimulate the extensor compartment and get those extensors a little bit stronger, we create a little bit more balance. So then we can reduce the amount that we have to inject them or reduce the doses. So it's a full package. We have to do all of those things together.
Do splints help with spasticity?
Yeah, so just as I said, yes, for the appropriate patient, very good for maintaining stretch. So once we do botulinum toxin, one of the key things is a stretching program, or using a splint to give you some passive stretch, like overnight or when you're watching TV. That can be like through an AFO or resting hand splint. And these are very important because spasticity is going to help us weaken these overactive muscles. But to maintain that effect, we need that stretch to be there. And that's what splints are really good for. So yes, we use bracing and splinting for that.
Is there any particular way to differentiate dystonia and spasticity?
It's just with the presentation. So like I said, spasticity is going to be a little bit more spasms, a little bit more with movement. So if someone's sitting there doing nothing, then their tone will kick in when they're trying to move or trying to do something. Dystonia is when you're just sitting there, you're in a weird and wonderful posture. When you're walking, you develop this weird posture when, like I said, that arm is really not really supposed to be doing anything and it's really out of place. So, and dystonia, when it comes to treatment, when we talk about something like botulinum toxin, much lower doses are needed because it's not such a big reaction from the stretch reflex. We don't have to overload that as much. So just small doses, much smaller doses can give us the desired response. Much more going to happen with like brain injuries and strokes than it is with something like spinal cord injury. So we won't see it very much in spinal cord injury.
I know you guys addressed this a little bit, but what are the complications apart from infection that could cause the pump to malfunction? Is there anything that you didn't mention, Stacey? You mentioned a lot.
Yeah, the complications with pumps, like an actual pump malfunctioning, I mean, they have a lot of internal parts. They have little cogs that turn and a tube and things that can break inside of them that will then cause them to alarm, without going into too much detail. But listed on the slides, yeah, there's not a ton more. There's mostly like related to pump is either the pump malfunctions or the catheter malfunctions. So you have sort of two parts to the system, technically three. There's an abdominal portion of the catheter and a spinal portion of the catheter. So there's connection ports that can break or come apart. Again, very rare, but can happen, which will cause leakage. The catheter can be like broken. There's a new catheter design, so it doesn't happen very much anymore. But they used to be able to kind of crack, and then you would get leakage in the catheter as well. Again, very rare, doesn't happen very often. But those are kind of the pump things that can happen.
Are there any benefits for splinting for dystonia? There's always been some pressure to splint from other team members. Somebody's trying to win an argument here, so.
Yeah, we don't generally splint for dystonia. It's this abnormal posturing. Like we said, it's actually like if you have them when they're not doing something, you can actually range them through a full range of motion usually. So it's very, very different to that kind of spastic myopathy we get with spasticity. So splinting them is not really going to change anything, right? This is a brain issue with pattern generation, abnormal movements, and so splinting is not going to do anything, right? So we don't splint dystonia. And there's a question above that we missed as well. Clonus was mentioned with the ankles, but is that the technical term for spasticity? Clonus is just one of the many reactions that we talked about, positive presentations of spasticity, and that's just the shaking that happens. And it can happen anywhere. It can happen at the ankle with that kind of plantar flexor response. It can happen at the wrist. It can happen with finger flexors. You can see it anywhere, but it's kind of just that jumping motion. So it's just another positive reaction of spasticity.
Okay, and our last question. I've been told that putting something in a spastic person's hand, like a rolled washcloth, stimulates a grip reflex. If there are no splints available at the time, is there anything else to help someone with the clenched hands apart from manual extension?
A washcloth will not necessarily stimulate a grip reflex. It can be very, very essential for people, particularly someone that's in long-term care or someone with high care needs. If they've got significant nails and they're digging into the palm and they're getting skin irritation and they're getting wounds forming in their palm, then we need to do whatever we can to keep their fingertips away from their palm. And so if that means a palm protector, a washcloth, whatever it is, you stick it in there. And then we obviously try and treat their finger flexors to try and relax that response so it's not as pronounced. But yeah, you need to use something in there to do that. So if it's a washcloth, that's fine. Versus palm protectors, there's other versions of palm protectors.
Okay, we have 2 minutes, so I'll ask the last one. Is there anything that we can do to prevent spasticity occurring in the first place, like range, splinting, etc.?
Yeah, so stretching is very important, right? So if someone comes in and they've got very limited mobility after their spinal cord injury, and if we just like leave them, that kind of positioning is very, very poor. So that early passive range of motion of all the extremities, maintaining the full range is super, super important. Can we do anything else? Stopping things, inflammatory things early on. So UTIs, pneumonias, prolonged ventilation, prolonged ICU stays, heterotopic ossification, anything in the acute phase that's going to cause inflammation will speed up the process of spasticity, will speed up this hyperexcitable state to happen. We can't predict, unfortunately, which patients are going to have how much spasticity. Sometimes some of my most incomplete patients or some of the more incomplete patients have really significant spasticity because they have some signals that are getting past their level of injury and they're like fueling the fire for some of this spasticity to develop. So you can't predict some complete patients, some incomplete. So that's the unfortunate thing. So all we can do is try and prevent it as much as possible with maintaining range for as long as possible, and then treating whenever we can.
And Maxine added, but even if they are flaccid.
Yeah, so again, like I said, remember spasticity develops after about 4 to 6 weeks. That's when that hyper-excitable state happens. Unless you've got like a chronic myelopathy. So this is common for us now is we're getting these people with 2 years, chronic changes. They haven't come into the doctor and they're just hanging out. Then all of a sudden they turn up and they've already had spasticity. They get decompressed and their spasticity is there from day one and it's ramped up to 10. Right, those people are going to be right off the bat. We've got to do something. But if you're a new spinal cord injury from a baseline, it's still going to take that 4 weeks to ramp up. I would still say you need to maintain a range of motion if they're flaccid, because you don't want to develop muscle contractures away from spasticity because of disuse. Remember, we have spasticity and then we have disuse. And if you leave someone immobile, their joints will start to not work as well, and they may develop more contracture, right?
Great, thank you, everybody. If there are any questions left in the Q&A, I will let these guys answer those questions in the Q&A.